Everyone, I think we're just about quarter 8, so I might greet you all in the afternoon session and thank you for coming. It's my pleasure to introduce one of the trusted voices in Australian public health. Kerry Chant has been a figure in public health microbiology in New South Wales since the 90s, when she was Director of Western Sydney Public Health Unit, and has been our leader as the Chief Health Officer since 2008. Kerry's been a trusted voice, as many of you would have known and heard, and is someone that has been awarded the New South Premier's Women's Prize for Excellence last year, and the Officer of the Order of Australia this year. So, Kerry, we're very grateful that you've been able to come and give us some time to tell us a bit about our last few years, in fact. So, Kerry Chant.
Thank you very much. And before I begin, I'd like to acknowledge the traditional custodians of the land on which we're meeting and pay my respects to elders past, present and emerging. The COVID pandemic is a long game with much uncertainty, and where we need to plan for the unexpected and continue to learn or evolve our response. As we navigate the pandemic, there must be a focus on overall health outcomes, not just a focus on COVID. And it's going to be important that we develop community and maintain community trust and effectively communicate the objectives of the response at each of the phases. Community and stakeholder engagement are the key, and we also can do that better. COVID has shone a light on social disadvantage and the need to address these fundamental issues if we are to make our communities resilient to the current pandemic and future infectious disease outbreaks. And I see this as one of the great learnings. It's around addressing accommodation issues, housing. It's about addressing vaccination hesitancy. It's around affording access to health care. We also have needed to draw on an incredible array of multidisciplinary expert advice to inform our response. Modelers, infectious diseases, communications experts, social researchers, logisticians, project managers. So one of the key learnings is it's about that breadth and how we bring together those multidisciplinary teams with those different perspectives. And I've got to stress the importance of the social researchers and communication experts as we attempt to translate very complex scientific concepts that we're really grappling to understand with COVID in a way that translates to an understandable message for the community. We also need to be really frank and open when evidence changes. And I think, again, this is something we can be more explicit about. And we've certainly had to change our position. I think one of the examples was last week, really, I think, understanding that people were confused. You know, we told people to get 2 doses of vaccine. What do we mean? We need 3. Their lived experience that friends and colleagues that have had vaccination are still getting COVID. What is going on here? And I reached out to a colleague, Julie Lesk, to sort of craft some words, but really being open that the virus has changed. No, 2 doses is no longer sufficient to protect you against severe illness. And what we need is 3, 4, or in some cases 5 doses of the vaccine for you to be up to date. And also being very open that the vaccine is holding up well against severe infection, but not so good about stopping infection. And that really means that our tools have to be effective, but we have to recognise that it's not going to help us as much as we previously had that help in its ability to stop transmission against, say, for instance, Delta. The other component of the response is the importance of data and measurements, and this should be shared. I think we've seen the amazing sharing rapidly of international evidence, and also it's been pleasing to see how states and territories in the Commonwealth have shared. But we can always do better in relation to data, measurement and measurement. I just wanted to briefly touch on one of the measures that have been looked at as an important global measure, and that's excess mortality. And the reason why there's been a lot of discussion around using excess mortality as a measure is that it picks up the both direct and indirect impacts of COVID on the community, and it also takes into account differences in ascertainment of causes of death, different classification, different testing capabilities and attribution. So I think this gives us a really interesting take. If we look, for instance, in relation to Sweden and Norway on the far right of the slide, we can see that even countries that are very similar have had slightly different experiences due to the policies and approaches they've taken. You can see that the red line represents excess mortality as expressed a rate per 100,000, and the pink is the deaths attributed directly to COVID. And you can see how in different countries there's a mismatch between reported COVID deaths and excess mortality that for most will actually be explained by under recognition of COVID or its direct or indirect impacts. We can also see back down in our left-hand corner of Hong Kong, and you can see that in a very low COVID environment, they've performed extremely well. But when they were exposed to Omicron, you can see that the absence of vaccination in the elderly has led to significant excess mortality. For us, we've travelled pretty well. We have not accrued as a nation much excess mortality, but certainly with the advent of the Omicron wave, we have definitely accrued excess mortality. And I think the question for us is what tools we can use to minimise excess mortality, and that's going to be about focus on COVID, it's going to be about focus on flu, but it's also going to be a focus on other chronic infectious diseases and their management. In terms of New South Wales, this is the ABS data. We're separately monitoring excess mortality. There's generally about a 6-week lag in excess mortality, but we are looking at some algorithms to get that down to 3 weeks, and therefore it'll be a much more meaningful contemporary measure of how we're tracking. This really shows that in 2017, you can see that there was a big excess mortality associated with flu. And I think one of the learnings and reflections for me is we probably really underestimated flu. We probably under-attribute deaths to flu. They appear as pneumonia. And I think the lessons we can learn is that some of our improved infection control can also help us reduce the burden of influenza and the importance of vaccination there as well. In terms of 2020, you can see that we had negative excess mortality in New South Wales, and for basically 2021, we had no significant excess mortality. It's basically followed the expected pattern. As I alluded to, in the Omicron BA1 wave, through the late part of December into January, we started to accrue excess mortality, and at the moment we're tracking within that seasonal range. We're clearly interested in what the impact of the most recent increase in cases will be on that excess mortality. The pandemic response is an incredibly complex one and requires the ability to work across government, business and the NGO sector and with the community. And I think the importance of optimising how these various players interact and support the COVID response is also another key lesson. So I'm just going to talk about some of the challenges, and we can obviously, in questions, you can tease these out a little bit more. But one of the key messages is the long game. You know, we always have to be looking to the horizon, and I think you know, facing that with uncertainty, but actually thinking about the various contingencies or scenarios that could arise and what our responses will be. But it's also around taking the community on the journey, communicating what is known and what is not known, But that's hard because the community becomes fatigued, messages become fatigued, and so we have to redouble our efforts to maintain some of those behaviours that we want to sustain. There are many of the behaviours that we've established over the last couple of years that we have to have a discussion with the community that we retain year in, year out, even if we get a magnificent vaccine that eradicates or suppresses COVID transmission to the lowest possible level. Even the impact of just mask wearing in clinical settings, mask wearing in places like pharmacies, doctors' surgeries. I believe that they are really important actions to take into the future, even in terms of aged care facilities, maintaining that visitor wearing masks, particularly in the indoor environments, is going to be a key. And I think we'll have seen that being a useful adjunct to our influenza management in the past. The importance of communication and trust and taking the community with you. And I'll take the next one together, which is keeping it simple, try to be consistent, flag changes early and engage with communities. And can I just say, I think this is where we can do better. I was just reflecting before commencing here that we love precision, we love the exceptions to the rule, we love the caveats, but that isn't effectively received or effectively heard. And so sometimes we've got to lose the precision of the message to actually make it more understandable. And that's really the challenge. Whenever we change anything, we've got to understand how that can create uncertainty in the community. So there really has to be an assessment of, is it that important, that imperative that you change? Because changing actually has negative impacts as well. So is it really necessary? We also need to be pragmatic, flexible and agile and incorporate emerging evidence. I probably could write a book on all of the things that we thought were true that weren't true now. And how do we actually have an open, transparent discussion with that and explain to the community why things have changed. And generally it's been because the scientific community has generated high quality evidence, though the virus has changed or there's been fundamentally new knowledge generated. The importance of experts is incredibly important, and as I talked about, the diversity of experts that you require and respecting the expertise across those different multidisciplinary teams. You cannot go into a pandemic response and build it whilst you're there. Now, obviously, we've had to scale, we've had to add new staff, we've had to do things differently, but you need the strong foundations, just like we need the strong foundations of a great healthcare system, a good primary healthcare system. All of those basic systems have to be nurtured, grown and maintained in order to almost mount an effective pandemic response on top of them. The importance of measurement matters, and that really is critical for us, because there were some times where Australia was in a unique situation of generating some of the scientific, the answers to scientific questions that couldn't have been answered overseas. We were a low disease country and therefore could actually, say, for instance, investigate transmission in schools and other settings in a very different way than perhaps in a high transmission context. So the importance of measuring what matters is also around hospitalisations and deaths, but also understanding the nature of those deaths. So data is incredibly important, and we need to make it transparent, but we also need to explain it. And I think there are many amongst the audience here that would question, why does New South Wales have higher hospitalisations all the time with COVID? And that's because of some of the data matching that we do that generates those hospitalisations, which includes both people with admitted there with COVID or with incidental findings. And that may be different in other states and territories. So being very transparent about the data, but also having a shared understanding of why there are differences. Maintaining a focus on overall health and wellbeing whilst continuing to learn and evolve. And so now the challenge for us is, how can COVID be integrated into our health system response along with other respiratory viruses? But also, how can we do elective surgery, how we can get people connected to chronic disease management. Our focus has to be on optimising health and putting the patient at the centre of the experience. So I'm just going to talk about the future challenges, and there are many. So just as a bit of a bundle, the co-circulation with flu and other respiratory viruses, new emerging viruses, and the re-emergence of vaccine preventables. So if we look at the co-circulation with flu, what we can see here clearly is the 7-day average of COVID notifications and hospitalisations. What you can see here is that there is generally a lag in the hospitalisations a couple of weeks before you see the increase in cases. There was a little bit of a variation later, just recently, and that's because what we believe accounts for that is that while case numbers were lower, there was actually an increasing proportion of elderly in those case numbers. And so what we actually think happened in the BA1 wave is that many elderly sheltered, but potentially those behaviours weren't sustained right through, or at some point they become exposed, and so it was a greater proportion of the elderly, which has seen an uptick in hospitalisations in that pattern. In terms of the flu notifications, again, we see that that pattern, but interesting, the flu hospitalisations usually go ahead of the uptick in the notifications. So again, we've got data monitoring infectious diseases, and I think you're all familiar with this sort of data, but I think some of the key issues is no longer can we really focus on notifications for influenza. As you're aware, most of the public health laboratories in New South Wales are now using triplex or duplex testing, so every patient gets COVID and flu, and sometimes RSV, a number of the private pathology laboratories. So laboratory, just pure case counts are not going to be useful. We believe that looking at the hospitalisation gives us the best comparative indicator, and obviously case positivity. So you can see the dark black line shows that we had a very early uptake in the flu season, and it's actually declining. Now, I think the magic question, and I was just postulating this with Dominic, is whether we will see a resurgence of flu later in the year. One of the other key challenges for us is understanding the new variants and forecasting what might happen. And we also need to understand the immunity profile in the population to understand and predict when new waves have come. We were predicting the B4, B5 wave for many weeks. We knew that this new variant had emerged overseas. It had a competitive growth advantage. We could start to detect it here, and we can use those projections in the modelling. So just wanted to talk about the S gene target failure. We've been a little lucky that the Omicron variants have managed to switch on and switch off this S gene target concurrent with the new waves coming through. So we went from Delta to Omicron, BA1, then BA2, and now the 4-5. And so what this shows is one of our private pathology providers, Histopath, uses a platform that detects the S gene, and then what they do is report to us the S gene target characteristics. And as I said, at various times we're either looking for failure or a positive affirmation. And then this allows us to track at a population level, because they're a large enough pathology provider that gives us a reasonably good case ascertainment, the ingress. And you can see the BA4-5 wave as tracked by that. And then what we do is we get them to send across some other samples that are not either the S gene positive or S gene negative, depending on the situation, and we sequence that to confirm the accuracy of this. And we're just currently looking at a new variant that's been reported, BA2.75, and clearly the question for us is whether we can use this system and we suspect we may be able to actually look at how that might be replacing it. So again, whole genome sequencing has been useful adjunct to look at it, and we have to change our testing genome sequencing. We can't obviously sequence every case. So what we do is we target and revise our genome sequencing strategy to what are the questions we're asking. So at the moment, we're asking, are we getting BA 2.75? And then we're also wanting to monitor and track the B4, B5. Are there any severity signals? So there's been no clear evidence of any severity signals against B4, B5, but obviously ICU admissions gives us some information on that, but some of the problems are that often by the time they get to ICU, they're not actually shedding viable virus sufficient for genome sequencing. We've been doing a lot of focus on return travellers because that tells us the virus is come in, but also it allows the laboratory, ICPMR, to get samples, to do neutralising antibody studies and to grow the virus. And as I said, we are looking closely at this BA 2.75, and we have detected it recently in some returned travellers. So one of the other next challenges we need to do is consider our testing and isolation approach. So at the moment, COVID is probably unique amongst the diseases where we actually require people to that test positive to isolate under a public health order. At some point in the pandemic, we will have to normalise this with the same messages of stay home if you're sick and only get tested if it's going to change your clinical management. So there's a lot of effort going on now to align and strengthen our messages, particularly to encourage testing in the groups where it will change clinical management in accordance with the eligibility for the antivirals. So that's a challenge that we'll have to have in communicating the future at some point, but not till we get through this wave, and hopefully we won't be confronting a next wave. One of the other challenges for us is the ongoing focus on vulnerable settings. And whilst when we were vaccinating the population, when we didn't have the full use of antivirals, we had to have very stringent settings in these settings to actually keep COVID out. With the more transmissible variants, we know that there's a lot of impact on aged care facilities, correctional facilities, disability facilities, but it is about balancing lifestyle versus disease progression, suppression. And whilst we're still taking very aggressive responses from an outbreak management perspective, we still need to be cognizant. And I'll pause for a moment so that you can read some of these slides, because these are quotes or letters that have come to us that really reflect why we need to get a balance between meeting people's social, emotional well-being as well as with COVID. Nosocomial transmission is a key issue. So because we have got such high levels of transmission in the community, keeping our healthcare facilities safe is going to be an ongoing challenge. We also have to be honest that it puts extra stress on our staff and other challenges. And so managing nosocomial transmission, keeping it as low as possible, is going to be a key challenge for us into the future. And at that time, I'd like to pause and take some questions. And I can call on you to answer, the other experts in the room to answer some of them too, if they're too hard.
This is on.
Fine.
If anybody has any questions, I can bring the microphone to you as well.
It's very glary.
Thank you for your presentation. I guess it's a huge discussion between state and national responsibility for a lot of these measures, but I have a particular question about the reporting of data. And Hearing from public health officials and researchers in other states, New South Wales has been held up as a kind of aspirational standard for the format of the release of data, the quality of the data, and the speed of the release of data. Is there any, there's obviously differences between states and how this is managed. Is there a way this could be harmonised, or is that any possibility of that in the future?
So look, I think it goes back to my point about the foundational building blocks. So just in terms of New South Wales, we have local health districts, but we are all part of New South Wales Health. And while we actually at the moment have, I think, 8 episodes of EMR, our electronic medical record data systems across it, we're actually moving to a single unified medical record and in the horizon, which will mean that that's amazing. So that's good. We also have a backbone of a health pathology. So Dominic Dwyer is head of the population health, sort of public health sections. Sorry, it's been a long 2 years. But actually having an integrated laboratory system. Now, that system doesn't work together. And so even when we were trying to manage sending specimens or decanting through the whole system, there were challenges because the laboratory information management systems weren't compatible. But guess what? We're actually getting a single unified LIMS system, which is fantastic. We went into this with a notifiable disease system, which was actually not bad. It was at its end of its, we're needing to replace it, but it actually had electronic notifications. It had a lot of the systems. Now, we've also very lucky to have eHealth, which is a backbone sort of structure that supports the whole electronic health sort of stuff across all of eHealth. So, for instance, they were really helpful in helping us keep that system alive because it never was envisaging the workload that it generated. So I think having that capability. We then had a great system in the clinical section of our department where we had this thing called the patient flow portal. So that actually has access to everyone's sort of data in a de-identified form that we can actually match to the NSIM. So that's why you'll see we tend to have higher numbers of cases because every day there's a matching of any patient that's in hospital that's got a positive COVID test. And so it's almost a census of who's in there. Now, many of those people will be there for COVID, but some will be incidental. So I think it's just for us, it's that. We've also invested heavily in our Centre for Epi and Evidence, and we've also got great partners. I'd like to, acknowledge the National Centre for Immunisation Research, the Kirby, who have helped us with some of the vaccine effectiveness studies. And so for me, the academic sector stood up in a way for this COVID that they perhaps hadn't stepped up before. I remember right at the beginning in 2020, one weekend where we had the first outbreaks in schools, calling Christine McCartney and saying, we haven't got time, we've got to focus on the contact tracing and doing all of our bits. If you want to come in and study transmission in schools, but you have to bring everyone yourself, you have to do the bloods, you have to do all of the stuff. You can't put any extra pressure on the public health because we're doing this bit. So I think that's a genuine partnership. And I think learning how to leverage off the great assets we've got in our academic sector is really important. So building blocks, and it's really hard to replicate that if you don't have some of those systems behind it. But we've still got a long way to go. And we've also secured some funds to do a new notifiable disease system because the last one has been put together, patched up and being kept going through our great eHealth colleagues. If that's a frank assessment.
Dominic.
We have some people online, I think, so the microphone helps.
Okay. Kerry, I just wanted to ask what your view was on direct-to-patient reporting of results, because that's occurred during this pandemic, initially with COVID, but now with other things as well, and what the pros and cons are of that in your eyes.
Look, fundamentally, the reason we wanted people to report was not that we were so fixated with counting, because we always know that counting's not counting cases is fraught. You're always underestimating it. What we were really motivated to do is make sure people were linked to care. We obviously had experience that primary care was harder to access at certain points in the pandemic. There wasn't a lot of experience around COVID. There was certainly access to antivirals. We needed to push messages. So we've really used the RAT registration system as a way of linking them to care, linking them back to primary care and general practice, and linking them to get prompt antivirals. So for me, that's been the major reason. I think we always have to accept that there is under-enumeration through our testing. And but the question is do we need to invest in really understanding that, or do we use other de facto measures such as hospitalisation and others to build up a pattern of the impact of a disease? But for me, it really was that linkage to care.
Martina, have you got some of those questions online? Or have we got access to them? I might ask Kerry, though, just while we're waiting, I'm interested in your thoughts on the sort of democratisation of the messages. You were saying before how important it was to have the partnership with the academic sector. And I think, the hungry news sector who wants an instant answer can't always get access to the health department for the sort of last word. So they commonly go to the academic sector. Do you think there are any sort of messages that you'd like to convey about how that relationship should work ideally? And do you think it has worked well in our last few years?
Look, I think that it's been really important to have diversity of views. I think it's really important to have different perspectives. I think we need to openly share the data so that there's shared understanding so the academics can understand. But I've been really pleased with the engagement of the academics. And as I said, I think, this is a pandemic. I don't think we really clearly know what the future holds for us. I mean, I think we would intuitively say we're very blessed with the vaccines. We've got antivirals. We sort of know the tools like mask wearing, how to protect vulnerable settings. We've got a lot of the tools, but the question is how to use them, and then what curveballs will COVID give us? I don't think anyone probably could have expected this year that we would have had 3 waves in the first 6 months. I don't know about you, but we certainly factored probably 2. But we've got 3 and it's June, and you just think, oh, good, 2.75. Yep, growth advantage, growing in India, genome sequences in UK. What does this mean for us? Good. 2 months' time, we might have another one, or maybe not. So I think that's been a surprising piece for me, just how, and maybe it isn't for the virologist. You maybe should comment, John. Were you surprised?
Not me. I'm not a virologist.
Dominic, were you surprised? Dominic, were you surprised by the its propensity to spin off?
Yeah, I was. I mean, I thought there'd be waves of activity, but the frequency at which they've arisen, I think, has been a surprise. I think it's how the whole global movement of viruses happened. It's become really obvious that viruses are going to come out of India, out of Africa, out of the UK and whatever, or even out of Australia, much more quickly than we might have thought. It's different.
That's right. And the other slide, I just wanted to, we are genuinely concerned about immunisation programs having been disrupted across the globe. And so we're really concerned about, measles, diphtheria and those. We've also been, monkeypox, we've got JE. So there's a lot of infectious diseases is actually really a growing, burgeoning professional career for you all. I think we just want it to stop.
Hi. First of all, thanks for everything you have done throughout the pandemic. So my question is, what can we, academics or scientists, do to have a better government that understands science better and supports it better? Like, what can we do? Like, should we go into politics? Should we talk to politicians? What can we do to make government more science pro, let's say?
Look, I think the issue is that even now it's really complex. I think you have key roles in the communities, your networks, your social networks as educating and informing. We actually have to have a complex discussion with the community about their preparedness to take some simple measures to public health and social measures. We know the vaccines are not going to help us with do too much of what we call the heavy lifting in relation to infection transmission. So we are going to need the community to take on some of those simple messages. At the moment, we've got really high compliance in vulnerable settings. So I want to just acknowledge that in our hospitals, in our aged care facilities, the question for us is what compact do we have with the community going forward? And, you know, I suppose I'm a little surprised that that it's still a struggle to get mask wearing in public transport, knowing it's often a very, you know, close confined, even though it's mandated. So I think that it's not a simple question of mandates or not mandates. It's a question of how do we sort of individualise the benefits, but then also draw on their community spirit to perhaps up some of the measures we want them to take to prevent the transmission. So that's a question. And then structurally, just keeping people informed about the role of ventilation and how you may make different decisions about, you know, your entertainment venues that you choose for your frail elderly aunt or mother compared to younger people. So we've got to arm the community with enough information and empower them. But you as individuals, as part of your communities, as part of your social networks, you can also reinforce the simple messages and increase that level of understanding. And I think, look, it's really hard. I mean, you know, we do tell, you know, we forget, like we live and breathe this, but, you know, people will have said to us, oh, I had you know, you told me to get 2 doses. And we've changed the message to now 3, 4, and, you know, if you're immunosuppressed, fine, whatever. And, you know, why has that changed? Have we spent enough time working with the community to understand that? So I think it's a lot of hard work, but you all have a part to play. You're welcome to go into politics. It's a democracy. But I think we've got to start at the very grassroots level, empowering health literacy, you know, and doing better ourselves. I mean, I think we learnt some really interesting things like, you know, stay at home with your family. Family for some CALD communities is, you know, more than one household, you know. So again, it's that testing the messages, making sure it's easily understood, making sure it resonates. So it's a long journey, and clearly we hope that there's a vaccine that can be more pan-coronavirus or more sterilising. But I'd ask the virologist in the room about the chances of us. Yeah. Who knows? And then we're learning so much about immunity, and I think that's the other emerging thread with the new publications around you know, immunity and how that works over time. So, you know, I'm privileged in my position. I am, you know, not an immunologist. I'm not an infectious disease doctor, but I get to interact with experts who can distill it. But when the experts themselves are talking amongst themselves and looking at the new publications and what does this mean, we as a scientific community are still navigating some of the answers in relation to the science around COVID and immunity. Unless someone else has got the answer to that.
I just might ask Kerry, while we're moving across to the next question, about this concept of surge capacity. I remember when this first started, hearing from colleagues overseas about universities looking to roll out sudden testing capacities and reflecting on the idea that it sounded quite chaotic. So if you look back on this, bit of crystal ball gazing in a few years' time, do you feel like this is been an episode that's a bit of a one-off where you've lent into the academic sector a bit for surge capacity in an unusual time, or is this the way things are in the future, that we will actually need to strengthen these kind of relationships in the future?
I mean, one of the things from the pandemic is, it's caused a lot of distress, a lot of challenges for many people through the pandemic. We've got to remember that. But there's actually been some things that we've been able to achieve through the pandemic that we would have never, in days to weeks, that would have taken us years, literally, to achieve. And there's many things that have been innovations that have improved access to care, like some of the telehealth stuff. I think the relationship with universities, for instance, bringing in the university students to do vaccination, I think they really enjoyed it. And we probably should make some of those clinical activities more mainstream and maintain that bond in a different way. We've had pharmacists vaccinate, and the scope of practice of pharmacists have really increased in terms of vaccination footprint. And the evidence we've got is that that's really good, because it really makes it accessible, particularly in some of the communities we want to reach. And so strategically, we were going to want to increase that capability and that, that footprint in terms of their capability of vaccination. There's probably just been so many things that actually have been positive. As we go through and document the lessons learned, we've got to still make sure we capture those and keep doing it, and just don't go back to, the way we used to do it, if this way was actually better, particularly better for the patient.
Yeah, thank you. I ditto the other comment. Thank you for your hard work. I must say that you're quite a comfort to see every night. Have you got a comment about in terms of informing the community, this pandemic was possibly one of the first where the information could also come from other sectors on social media and internet. And it wasn't always correct, as we know. Have you got a comment about how to handle those sorts of messages that get bandied about?
Look, I think, traditionally, this will be for the social scientists and a whole range of people to actually reflect. But I think there has been some narrative around, did we get in early enough with stomping on some of the anti-vaccination myths? There's always been a challenge, because there's been a narrative that you don't want to give too much airtime or equal airtime to some of the anti-vaccination thoughts. But I think social media has actually just put we're going to have to learn how to work in a different way. That's not my area of expertise, but I think I really respect our social media and comms team. I respect our social researchers, and we really need to learn the lessons of when to interact, in what platforms, what's the best way to counter those messages. But there's still an issue today. And it's also why, some platforms are reluctant to put out some messages, because they get so much orchestrated backlash. So, and I think we're going to have to learn, multifaceted communication, all the way down to the grassroots, you talking to your families, that extended way, through schools, how do we embed some of these concepts in our curriculum around viruses and vaccines as part of our normal thing that children learn in schools. All of these little ways will just mean that we've built those foundations for the next time we have to mount a response of this complexity. And I think it's really reasonable from the outset to perhaps be more upfront about information will change. We'll tell you what's right for that time, and we'll explain when it changes, because I think the changes perhaps were perceived, could have potentially added to distrust or misinformation.
Yeah, look, I guess this is more of a comment, but I'd be interested to hear what you think with respect, and it follows up on your commentary around getting the right message across to the community and vaccination. And if I think back to the early literature on the vaccines, particularly in the animal model testing and then in the early stages of administration, it was very clear that the vaccine was protecting against lower respiratory infection, but not upper respiratory infection. And it seems like that message has got a little bit lost on the way, and the expectations of the public that these vaccines are going to stop everything. And I think that's a really important message that we need to start reinforcing and getting back out there to people so they actually understand what these vaccines can really do.
Look, I think that's a key point, and I think I touched on it in my talk that, you know, basically being very open that the vaccines are good at protecting us against severe infection. We need to be up to date, according to the ATAGI advice, to be optimally protected because immunity wanes. And that concept that we can't rely on them so much for the infection prevention aspect. It's really more the individual protection. And that's why we need a holistic set of measures. You know, that's why we need to try and promote some moderate other public health and social measures when we're going through the waves.
Dr. Chant, thank you for your talk. Hey, over here. Thank you for your talk and thank you for your service over the last couple of years as well. I'm interested in your comment from before about case numbers inherently being fraud. Of course, I think most people in the room, it wouldn't be a surprise for. But then I'm interested to hear your thoughts on, I guess, our national almost obsession with case numbers. And from a public health point of view, was that something that was, I guess, helpful in helping people follow the instructions, or was that one of those things that sort of diluted the message that the government was trying to get across?
Look, I think case numbers are important at various stages and your case ascertainment changes. So, for instance, during Delta, we had really good case ascertainment. I think if you go to COVID Live, sorry to give the thing to a whatever, but COVID Live, you can really look at our PCR positivity rate was down about 0.3. So clearly we were very much picking up the vast majority of cases. There would have still been some under ascertainment, but it was pretty good. But if we're now, our positivity, I think is around 16, it's gone up to 20% at times. So clearly we're missing lots of cases. So I suppose it's the fact that we need to look at all the data points and triangulate them. So it's not good to just see case numbers in isolation. If you've got decreased access to RAT testing or you've got weekends, you have to understand the drivers behind it and the context. And I think that's important as we all prosecute the data and literature from even overseas. We need to understand the context in which that data was collected and triangulate it. And does it make sense?
Kerry, I'm going to paraphrase. It's on now. Kerry, I'm going to paraphrase a question that's come through on the online chat, and I'm going to ask it in a slightly different way, because I think, this room of people, we are scientists, we're microbiologists, we believe all of the things that come out of the data. And yet, yesterday or the day before in Melbourne, the messages that came through the politicians did not agree with what the health messages were. So I guess I'm not quite sure if this is a question or just asking you to comment. I think, from what we see, there is clear health data that we need to tell the public, but that's not always what comes through from the politicians. And that must be a real frustration for you for all of you working in public health. But I guess, how do we get around that? Because clearly what's happening in Melbourne right now is not quite the right thing for public health purposes, but our politicians seem to not want to do that. And we have what we see as quite a high death rate at the moment. But there's it's being swept under the carpet, really. And those case numbers that we used to see every day, you have to go and search for them now. They're just not out there in the same way that they were. So I'm not sure how much you can comment on that, but it would be good for us to hear.
Look, I think this is where I think we actually need to engage the community. I actually was reading a really interesting Guardian article. I won't quote it because it's probably bad, or I shouldn't. But I think what they were actually doing is putting together, they'd asked some questions or from a survey around how many deaths would people tolerate. And it was actually fascinating because people's tolerance for deaths from COVID was actually incredibly low. Like they wanted under 100. And we know that even in a seasonal flu season, we would be seeing, you know, as I said, the excess mortality in 2017 was around 2,100 deaths in 2017. And again, the flu data really probably misrepresents the actual impact of flu, because most of that excess mortality occurs in the peaky flu season, and that's probably attributable directly or indirectly to the impact of flu circulating. So what I suppose, going back to your question, is we do need to have a conversation with the community about what measures they're prepared to take. And in this article, the acceptance of death was very low, but then when you ask them would they wear masks or would they do other things, it was actually a total dichotomy. And so again, it's really around navigating that, because there's no point in having a mandate if there is not community support for it. So I really do encourage us all to use our social networks and others to explain what that can do. You know, decreasing the spread of the virus, keeping it lower than it is, will mean that we have less people going into our aged care facilities inadvertently positive. It'll mean less disruption for schools. And so if we can all do a little bit, it can actually slow the spread, and that's, you know, supported by modelling data. But we all have to do it. It's not like a microcosm. We actually need that mass impact to have that high levels of mask wearing, particularly indoors. We also need to make sure people are staying at home when they're sick, and doing those other protective measures. So I'm sort of more like, we have to actually have this conversation with the community and get the community on side, because that's going to drive better outcomes for us. And I think the community, perhaps we didn't actually explain enough to the community what living with COVID looked like. You can see the countries that have transitioned. And I think reflecting, I think Singapore has, if you want to, I remember recalling reading one of the Singapore leaders' speech to Parliament, and it was right at the get-go, and it actually articulated that what they were trying to do is wait till they had all the tools that would make the death rate from COVID equivalent to what they were seeing with flu. You know, they'd accepted seasonal flu deaths every year, and what they were doing is trying to wait till they had a situation and manage it to that. So that was a very clear objective right from the get-go. And I think in transitioning, the evidence of the fact that we would be seeing deaths, that we would be seeing people hospitalised, probably wasn't as clearly communicated. And obviously, no one expected Omicron to come when it did. The disease was actually pretty well controlled in New South Wales going into the Omicron wave. We'd got down to very low numbers. I was reflecting on that data yesterday. I think we were down 149 cases. Clearly, the capacity for the vaccine to prevent transmission, particularly in that freshly vaccinated population, was pretty good. And then the thought is we were going to get some boosters. So I think we've also got to remember where we were and how much we changed. I think it's also really important that at the beginning, how many of you thought we'd have a coronavirus vaccine as quickly as we did? So Dominic, John, are you going to fess up what you thought at the beginning? A couple of you did. So I think that, we've got to take the community on the journey of what we know, what we don't know, and what they're prepared to do, because in the end, we've got to get the community on board to these changes. And what I would really like to see is a discussion about how we sustain these changes, year in, out, because they're sensible. The amount of people that go to a pharmacy for cold and flu medicine in those short little aisles, you know, everyone should be wearing a mask in that setting. It's just, it'll stop your flu, RSV, a whole lot of other things, and good hygiene. So there's many things we need to sort of just talk to the community about whether they're going to be tolerant to embed that. And I think you all have a role in championing that.
Okay. Kerry, thank you for the talk. I think, I don't know whether it's going to be a question or I'm asking for you to comment, but I think as a country, we have a pretty good system with, tackling this COVID pandemic, but obviously it is a global problem. So do we have any plans in the near future to help other countries, like developing countries who, struggle with just, getting the vaccine? I've heard of stories where a family would just, like the whole family in a developing country, where they would have to share one same swab, put into everyone's mouth and noses just to get a result. Or they can't afford to get a second vaccine. So, do we have any plans to support those countries?
So most of the support, I mean, there has been some support from the state, where I know we've provided some products from stockpiles to developing countries in our region particularly, but that really is a matter for the Commonwealth, and I know they actually have supported vaccine access to a large number of countries. So I think it's a really important point that in the end this reflects the equity, and we've seen disparate impacts in many countries, particularly developing countries. And I think that's probably our challenge for 2022. Whilst I am spending a lot of time on COVID, we can't sort of think about COVID in isolation to other respiratory viruses and their impact. Like when we're looking at influenza, we've got more children in ICU or impacted by influenza than we have. And we've got a vaccine that we've only got about 20 to 30% vaccination coverage for our under 5-year-olds. So there's so much we can do at protecting the community from infectious disease more broadly. One of my key passions is hepatitis C, and I really want to make sure that we reinvigorate our treatment of hepatitis C. Australia is well placed to actually eliminate this disease. Like, we have all the tools, we have a great system. We are treating more people in our corrections facilities, and it's amazing. But we've got to start to refocus on those. So 2022, we actually have to keep our eye on COVID, but we also need to refocus on all of the others, as well as the other emerging threats. Like, I'm genuinely wanting to make sure that our childhood immunisation coverage doesn't suffer because of vaccine fatigue, and we need to get in now. With a tired workforce of GPs who we've asked to give antivirals, see more respiratory illnesses. So that's the challenge we've got in the health system, is to optimise outcomes.
Kerry, we're just about on time, but I can't resist asking if you've got any closing remarks about people who'd be watching online and even in this room who are training in microbiology right now, about what future prospects look like. Where should they be turning their eyes?
Oh, look, I just think it's been like, what disease this week?
I meant in terms of skill sets, the sort of things that you value in your...
Well, I think the key message for me is that diversity is great. Take your time getting where you want to be ultimately incredibly passionate, but don't be in a rush. Balance your lifestyle and other things, but follow your dream. And you can have a journey from micro to public health to other settings. So again, just follow your passion would be my message.
Lovely closing message, one of Australia's champions of public health. Thank you so much, Kerry Chant.